All right, so this is the normal anatomy of the human heart, except that the top chambers of the heart are larger than they should be. For the purpose of this drawing, this is the right side, the left side here, the feet, the head, and we have 4 chambers. Upper chambers are called atria, or atrium, and of course we have a left and a right, and the lower chambers are called ventricles. And we, of course, have a left and a right. Notice that the left side is much more muscular than the right one. And that's for a reason, because this is the side of the heart that pumps the blood throughout the aortic valve into the aorta to the rest of the body. So this is a very important part, very muscular. You need it to be muscular. And you notice this little cords, those little strings that are holding what looks like a canopy of a parachute. These little cords are called chordae, and this is the mitral valve. And the mitral valve has 2 sides. You're seeing a profile view. I try to do a little bit of a 3D reconstruction of it. But if I look at the valve from the top, what you will see is basically this. A smiley face, okay? And this would be the ventricle going down. This would be the muscles, just like the other picture. And you would see the chordae going to the muscles like this. So that's the mitral valve. The mitral valve has an anterior leaflet and a posterior leaflet. All of this is the posterior leaflet. All of this is the anterior leaflet. I'm going to turn this and draw another one. So when we're talking about the mitral valve, in general, we will have the smiley face configuration, which is very real. That's the way it looks, actually. We have the papillary muscle. All of this is muscle, and that is called the papillary muscle. We're going to call it, for this purpose, pap. This is the heart muscle, and the chordae are going to be going like this, attaching each of the leaflets to the cords. We have several dozens of these chordae. The valve that you see here is closed, okay? That's how it would look when it's closed. If the valve were to open, the orifice would be like this. And all of this area is for blood passage from the top chamber into the lower chamber. When the heart beats, then the blood exits the ventricle through the aortic valve in this direction. And only that way. If you notice, these appear tense and the strings are stretched because the pressure within the ventricle that wants to push the blood out makes the 2 parts of the leaflets check. So it's almost as if you had 2 hands that are opening and clapping together, and this is called coaptation. The fact that they touch each other means that there's no blood passage upwards. What happens when you have mitral regurgitation? Well, that's a different story. Let's look at it in a different picture. When you have mitral regurgitation, you have your aorta here. You have your atrium, and here's the anterior leaflet of the mitral valve. Here's the muscles. And the posterior leaflet of the mitral valve could have this: a ruptured cord. Okay, so you have cords here that are normal, cords here that are normal, but this one's a ruptured cord. Notice the gap. And that gap leads to blood going out this way as normal, but also this way. And that is a tremendous amount of leakage because the gap is big enough that it almost matches the orifice of the normal valve that's supposed to let blood out. So this is what we call a flail leaflet. In this case, if you remember the distribution of the valve, we said that there are anterior leaflet and posterior leaflet. So this is a posterior leaflet flail from a ruptured cord. And what caused this cord to rupture? Many things. But in fact, we don't really know that there's a genetic makeup that predisposes people to have this happen. The rupture cords can happen in any age group, young, old. I've seen it in 21-year-old athletes, and I've seen it in 80-year-old priests, like I did today. And so it's random. What makes it rupture and then lead to the leakage, nobody knows. But the fact is that this is called, and this is very important, it's called degenerative mitral valve disease, as opposed to other forms of mitral valve disease that I'll talk about in a second. But this is degenerative, which means it's a problem that was a mechanical problem, clearly a ruptured cord, that now requires a mechanical solution. Okay? It's not that the heart enlarged and opened up the orifice more. It's nothing to do with that. It's a ruptured cord that needs to be repaired. And we can repair that. In fact, this is the most common form of disease of the mitral valve that we repair. In fact, the main treatment for degenerative mitral valve disease in patients who are symptomatic, and even in those who are asymptomatic, is mitral valve surgery, mitral valve repair. So when I say asymptomatic, well, wait, you have leakage, but you have no symptoms. How could that be? Well, at the beginning of the process, if you plot the symptoms of somebody who has mitral valve disease, let's say, an example, a 50-year-old woman suffers a ruptured cord. One day she feels short of breath doing grocery shopping. And what happened? I was really winded that day. I remember that day. And it went away. It went away, or at least I got used to it. But now I can't go uphill. I can't do 2 flights of stairs, etc. Well, the symptoms, if you plot the symptoms against time, and this is time, and these are the symptoms may be acutely present when the rupture cord happens, and they plateau. And then over a passage of months, sometimes years, the symptoms may exacerbate depending on the circumstances. For example, you went out, you ate too much salt, and you drank too much fluid, and you're congested now. Your heart is congested, so your symptoms exacerbate from your baseline. And then as the heart starts changing, and the heart will change when you have severe mitral regurgitation, then the symptoms become more prominent, and they just become permanent, period. And there's no regression. You can't go back. You do not go back once you've escalated to that level. So treating mitral regurgitation in asymptomatics intends to treat patients when they're here, when they have severe mitral regurgitation, have not developed the symptoms, but you want to prevent all of this. Because by the time you're here, this 50-year-old woman has a depressed heart. What do we mean by that? If you've heard of what we call the EF, the ejection fraction, which is how much power the heart can generate, normal EF for a human heart is 60 to 65%. Well, at this point, and that would probably happen right down here, okay? But at this point, that may be 35 or 40%. And if we had more paper, we can get to 20 or 10. In fact, we have patients in the intensive care unit right now that require a pump to assist the heart because they started out with mitral valve regurgitation and ended up with a very poor heart. The bottom line is, why do we want to treat them here when the damage is done? It's like treating a diabetic when he's lost his toes and his legs. Treat the diabetes before loses the eyesight, the feet, the kidneys, right? That's why treating here. Asymptomatic patients. But wait, there's more. So the idea is treat them if, number one, they have over 95% chance of repair. Not replacement, repair. And that's an important concept because many publications in the medical literature have shown that a mitral valve repair is so much better than a mitral valve replacement in terms of long-term durability, especially in the younger people. If you're 50 and you have a mitral valve repair, you'll probably make it to 80 with that same repair, and that's it. But if you put a mitral valve prosthesis, a man-made valve in there, you may have that valve go bad in 15 to 20 years, maybe sooner than that. And then you need a reoperation. So the first thing is that you need to have over 95% chance of a repair. The second thing is that you have to have a mortality chance of dying less than 1%. So you have to go to a place that does this day in and day out. because if you have a 5% mortality for an elective mitral valve repair, I would suggest you should not be doing this. Okay? So having said that, asymptomatic patients, early on in their disease, if they have over 95% chance of getting fixed with less than 1% mortality, they should be treated. And how do we treat it? Well, the way we treat these patients at Christ Hospital is, pardon my little cartoon, but if this is a human being, in the old days we used to do a median sternotomy. That's a median sternotomy. That's the breastbone split in half, okay? Clavicles. We don't do that. In fact, we don't do that, at least for mitral valve repair. We try to approach it through a less invasive means, which is, here are the nipples. We do a fourth space mini thoracotomy. It's a 3 centimeter incision. That's very small. And we do a small incision right here in the groin. It's about 2.5 to 3 centimeters. And through that, we can actually see the heart very well. The heart would sit like this, and the mitral valve would be right here. So you can see how we can see the valve very well from the right side. So that's a mini thoracotomy. That's a minimally invasive approach. And quite frankly, patients tolerate that very, very well. They recover very well, much better than with a sternotomy. So the time off work, the time off doing the things patients would like to do is so much shorter. So that's how we do them. In terms of how do we repair it, let's go back to the old picture of the broken valve. The goal is to make it look like a smiley face with a nice posterior leaflet and a nice anterior leaflet. And so in a rupture cord like this one, you can see the flopping rupture cord. What I will do is I will use something called Gore-Tex. That is, I won't mention the chemical name of Gore-Tex because it's too long and difficult to pronounce, but it's manufactured specifically to repair mitral valves. And it is anchored right here on this papillary muscle. And it has the following configuration. It has 1, 2, 3 cords and a set of needles. So with these needles, I will anchor it here. And the length of these cords varies from person to person. So in the operating room, we will measure the distance from the tip of this muscle to the edge of the normal leaflet. And that's the length that we will anchor. So we will basically put these cords here and suture them to the mitral valve to bring that scallop down to where it should be, effectively making it look like this. So this would be our suture with 1, 2, 3. Assuming that this portion right here was the segment that was prolapsing before. And then we complement that by putting what we call the annuloplasty ring, which is nothing but a man-made semi-rigid ring that is also sized to each patient based on the circumference of this valve and the diameter of the valve. And each person is different. But in general, with this technique, we managed to put very large rings, which is what you would like to do to prevent this valve from being too tight. There is such a thing as a too tight a valve. That's called mitral stenosis. And oftentimes when valves get repaired, they may have to put a smaller ring to make it competent or prevent it from leaking. And in turn, the patient may get mitral stenosis sooner or later, but they can. I would say that the vast majority of patients that have mitral regurgitation are asymptomatic. We only see the tip of the iceberg in patients that present with symptoms. So how do you know you have severe mitral regurgitation? The typical story goes like this. I went to get a checkup with my doctor. He heard a new murmur when he auscultated me. And that new murmur wasn't there a year ago, so he decided to get an echo. So he sent me to Christ, so I got an echo, and the echo demonstrated severe leakage. And then that severe leakage warrants a referral to a cardiologist and a surgeon to evaluate the patient. In our hands, we have that prerequisite that I wrote here about having at least a certain chance of having a repair and a mortality. So in our hands, what would happen is if you are a candidate to surgery, then you would be directed in that route, and we would complete a workup to know that the operation would be safe and undergo the operation to get it repaired. You stay in the hospital between 3 and 5 days, and then at home, you're basically doing all the things you used to do before surgery, except driving. We see you in the office at about 2 weeks after the operation, and after that, you're back to doing whatever you want to do, period. So that's how we fix these valves at the Christ Hospital. So I would say that the take-home messages are, one, that severe mitral regurgitation with symptoms or without symptoms should be referred for a specialty center like ours to be evaluated. And we usually, it's a cardiologist and me evaluating patients with mitral regurgitation. And we will have a fair assessment of what the patient needs and how the patient can be helped. Not everybody's a candidate to have open heart surgery. And for those who are not, we have other therapies that we can use to help them feel better too.